Provisions under the Affordable Care Act aim to enhance coverage, benefits, and access to care. The Affordable Care Act, or ACA, includes a Medicare provision that enhances coverage, makes changes to the provider payment, as well as increasing premiums for higher income beneficiaries. One goal under the coverage enhancements is to close the Medicare Part D coverage gap by 2020. This coverage gap is defined by Medicare.gov as the temporary limit on what drugs Medicare Part D will cover. The gap begins after the plan and patient have spent a certain amount for the drugs that are covered. Another coverage enhancement under this provision, according to the Kaiser Family Foundation, is to prohibit Medicare Advantage plans from forcing increased higher cost sharing requirements for a few benefits. Provider payment changes will be made under the provision by terminating cost sharing for covered preventative care, lessening payments under Medicare Advantage, payment updates, and disproportionate share hospital payments. General changes under the ACA provision include enlarging Part B and Part D payments for covered persons with higher incomes, creating an independent payment advisory board for suggestions to decrease Medicare per capita spending, and initiating changes of the quality delivery and payment system. Medicare has significantly boosted access to medical care for the elderly. As a future acute care and gerontological nurse practitioner, Medicare will be a significant staple to my practice because of my clientele demographic. DeWalt, Oberlander, Carey, and Roper describe how Medicare has also assisted in the areas of quality improvement and evaluation of medical practice. Quality improvement of healthcare organizations was established after Medicare's initiation due to the concern of unnecessary practices, and that kind of created a medical system of check and balance. Strategies to evaluate medical practice also commenced post-Medicare enactment to provide understandable and straightforward information on the patient health outcome. As a nurse practitioner, I'll be serving adults and elderly patients on Medicare. Coverage for Medicare begins at 65 years old for qualifying elderly individuals and young individuals with disabilities. Chronic conditions and poor health are more prevalent within the elderly community, therefore proper insurance coverage is needed. And it's my responsibility as a nurse practitioner to work with the insurance companies to provide adequate and appropriate care for my patients. Medicare is a government entitlement program that allows any person who needs coverage and meets eligibility standards to enroll for coverage, and is guaranteed total benefits no matter the state of financial burden of the government. This federally funded health system, according to Milstead & Short, ensures coverage to around 55 million people who have paid into the system for 10 years, or younger patients that have disabilities such as ALS and ESRD. Although Medicare does cover most things healthcare related, it does not cover permanent nursing home stays and long-term services. Currently, Medicare is made up of 4 parts. Part A assists with payment hospitalizations, home health, and hospice. Part B assists with payments of doctor's office visits and mental health services. Part C, or otherwise known as Medicare Advantage, entails private plans who receive payments to cover benefits, and Part D assists with prescription drug coverage. Under the ACA, according to Milstead & Short, in 2017, Medicare implemented means testing, where enrollees with higher incomes paid higher premiums. And in 2018, under the Medicare Access and CHIP Reauthorization Act of 2015, beneficiaries with a higher income greater than $133,000 pay a greater subsidy. As of today, the thresholds for income-related premiums have halted under the current law until 2019. Past proposals to reform Medicare have failed and succeeded, according to Roberts and Frog. Bill Clinton's 1999 proposal of Medicare had positives, but it ultimately failed to pass. Under Clinton's proposal, the authority of the Healthcare Financing Administration would be expanded. Private plans could rival Medicare system for enrollees. Americans 55 to 64 could purchase into the system, and $432 billion would be used to support Medicare. Roberts and Frog explain the downfalls of this proposal. Expanding the HCFA's powers would allow the government to give beneficiaries whatever they decided was the best deal, and that wouldn't enlarge ethical bureaucracy. Economically, it would be entirely more costly to American taxpayers than the $374.4 billion that was previously indicated. Legally, this proposal would have set the precedents for multiple lawsuits because the structure of the pharmacy benefit manager was not clear regarding which manager would run the region of America. The next passed Medicare proposal would be the Medicare Prescription Drug Improvement Act, or MMA. George W. Bush successfully signed this reform into law into 2003, and it did not take place until 2006. This was established to attempt to relieve patients of some of the financial burden of prescription drug costs. So what did this proposal actually mean? Brinkerhoff and Coleman describe in simple terms what the MMA of 2003 entailed for our country. Under this legislation, an optional prescription drug plan covers all drugs, including insulin, supplies, biologics, and some vaccines. Beneficiaries who opt for this plan are covered for out-of-pocket expenses at 75%. The coverage gap, as mentioned previously, begins when patients spend more than $2,250 and beneficiaries are expected to pay 100%. But when the spending reaches $5,100, beneficiaries are only expected to pay 5%. Economically, expanding any federally funded coverage comes at a high cost for taxpayers. Brinkerhoff and Coleman estimated that Medicare and Medicaid services would cost over $720 billion for 10 years. Politically, this law was not met without opposition and narrowly passed legislation. Many thought it was not detailed enough, and according to Jake Tapper and Dan Morris from ABC News, it was a ramrod down the throat of America. Ultimately, this act did ease the financial burden of some enrollees if they opted in. The ACA proposes more changes to Medicare than the Graham-Cassidy-Heller-Johnson Amendment, but does more changes always mean a better outcome? Under the ACA, the coverage gap will be closed hopefully by 2020, while according to the Kaiser Family Foundation, the Graham-Cassidy-Heller-Johnson Amendment plans not to change benefit enhancements under the ACA. The GCHJ also plans to leave reductions to Medicare and Medicaid provider payments unchanged. Higher premiums for higher individual beneficiaries will also remain. The ACA also permits independent payment advisory boards to suggest ways Medicare spending, in which the Graham-Cassidy-Heller-Johnson Amendment will keep as well. Payment quality and delivery changes, as well as enlarging ways to control costs and ensure proper care, will be established as well. The Kaiser Family Foundation remarks that there are some changes within the ACA that the Graham-Cassidy-Heller-Johnson Amendment will not pick up, such as removing cost sharing for preventative care, decreasing updates for Medicare, and accepting hospitals and provider payments, as well as lessening Medicare disproportionate share hospital payments. Many recognize the Graham-Cassidy-Heller-Johnson Amendment by the rant of Jimmy Kimmel on his show regarding the treatment for infants with heart attacks. He argued or heart defects. He argued that infants born with heart defects would not receive proper care within the first year of life. In my opinion, the Graham-Cassidy-Heller-Johnson Amendment would have improved health care within America if it would have passed the Senate. The overall goal was to return the power to the states with the equalization of Medicare and Medicaid funding across every state. Under the amendment, according to Elaine Ellis, states would have been able to waive premium rating rules but keep private market rules. Community health care centers, which is they're great places for preventative services, would have received supplemental funding of $422 million for the 2017 year. Block grants would have also been established so that states could furthermore choose how the lump sums of money would have been spent, as well as maximal contributions to healthcare savings accounts would be established. The United States government can only do what it can. It can only do what it can afford and base its reform off of other established countries with socialized medicine. Although it seems no healthcare reform will ever be ideal, state healthcare power would in turn let citizens have more power as officials voting and creating reform are elected.